we did this combination of azacitidine, venetoclax with magrolimab, and what we're seeing now is that the response rates are close to 85-90% compared to 65-70% with azacitidine venetoclax. But more importantly, the true CR rate, or the complete remission, meaning there's a full count recovery as well as a marrow clearance of disease, is almost at 65%, which is better than the 38 to 40% that's been reported with azacitidine and venetoclax. Even more importantly, in the very, very high-risk molecular group of TP53 mutated AML, where azacitidine venetoclax actually did not show a very clear benefit, now that we're looking at the data retrospectively with the response rates of only about 35-40%, true CR rates about 20%, we see that the triple combination of azacitidine, venetoclax, magrolimab actually is showing a very high response rate, with the overall response rate and a true CR rate of 65%. So we think that this triple regimen is adding to the azacitidine venetoclax in general AML, but especially in the high-risk TP53 mutated AML. And to evaluate this further, our single-arm study that was done at MD Anderson is now being expanded into a multinational randomized phase 3 registration study to look at this triplet, azacitidine, venetoclax, magrolimab versus azacitidine, venetoclax, and placebo. That's called the ENHANCE-3 phase 3 registration study. It's just starting enrollment. And of course, if it's positive, we'll change the nature of frontline therapy for all older unfit AML, which is about 60% of all AML. So it could be a major impact on the treatment landscape if it comes out positive. That's a very important question, looking at the safety of combinations, especially the so-called triplet combinations, where we're adding a third drug to the backbone of azacitidine venetoclax. And the main issue that we've seen, and the main concern that many investigators and experts have, is that when we add a third drug to the backbone of aza venetoclax, there will be increased myelosuppression. And this is because azacitidine venetoclax as a doublet itself tends to cause significant neutropenia and thrombocytopenia, with many patients taking between 30 to 45 days to recover their neutrophils and platelets. And so whenever we're adding a third drug, we have to be very careful to look for that signal. We have seen actually with this triplet, the azacitidine, venetoclax, magrolimab, that we are not seeing a prolonged neutrophil or platelet recovery time. In fact, we reported at the ASH meeting among the frontline patients, the median time to recovery of neutrophils was about 28, 29 days, and for recovery of platelets was actually about 26 days, which are actually very similar, in fact, maybe even a little bit better than what has been seen with the azacitidine venetoclax doublet. So we're very happy with that aspect, because with some of the other triplets that we and others have been developing, such as FLT3 triplets or antibody drug conjugate triplets, we actually do see that the count recovery is significantly prolonged, but that was not the case. And that probably is because the magrolimab does not have any neutropenia, thrombocytopenia in as part of its own safety profile. Now, we do see anemia. This is pretty common. This is seen in about 30-35% of the patients. Usually is very predictable, occurs after the first or second dose of the treatment, and usually resolves by day 7. So we usually watch these patients closely. In our institution, MD Anderson, we actually admit them usually for the first 2-3 weeks for monitoring anemia, thrombocytopenia, infusion reactions. Overall, the anemia is mild. The median drop is about 1 to 1.5 grams hemoglobin, but we have seen in about 20% of patients there can be a greater than 2 gram, and in about 8 to 10% there can be a greater than 3 gram drop. So we definitely don't want to take it lightly, and usually once we monitor it, transfuse it after those first 2 doses on day 1 and 4, we see that the anemia signal is not a major issue, and patients tolerate the treatment quite well.